So my name's Marshall Summer. I'm about a year new to the area. Moved here from Vanderbilt University. I was down there for 25 years in genetics. We've had a little bit of growth since I got here. We had about 3.5 geneticists in the division. As of the end of July, we'll have 12 and probably be adding a 13th next winter. All of our new geneticists are double boarded in both biochemical and clinical genetics, so they can handle both newborn screening as well as your classic dysmorphic cases. And we're trying to work with the nurseries in the region too to provide either remote evaluation of patients. We can also do that with offices, but we can talk about that later. Why do I like talking about newborn screening? Well, when I started off in genetics, most of the things I saw were kind of like, well, I'm really sorry your child's got that, but there's not a whole lot I can do about it. And this is about the time newborn screening was starting to become popular and really start to hit the mainstream. And suddenly we had a whole group of diseases, PKU, galactosemia, and others, where actually if we caught these early enough and we did the right things, we could actually turn up a normal patient. In fact, my very first PKU patient is now graduated from college and is a golf pro at a course down in Tennessee, so he's actually having a much better time than I am these days. However, that same patient, untreated, would be institutionalized, unable to walk, have an IQ in around the 25 to 30 range. So newborn screening is one of the things where we've had a tremendous impact, and actually I think have helped out as far as general health care goes. Now, most folks, when you think about newborn screening, think about the PKU test. You know, that's kind of the classic we all talked about. So I want to give you a little bit of history stuff about newborn screening. We'll talk a little bit about what some of the current recommendations are from the American College of Medical Genetics. Some of the newborn screening performance, how accurate is it, how likely is it to be a false positive, a false negative, sort of what I would say news you can use in your practice. What types of short-term follow-up do we recommend and do, and confirmation, and kind of what's coming down the pike in newborn screening. And there are definitely some new things coming down the pike in newborn screening. And I'll close out by telling you some of the things we've done at Children's to try to help you out with that. So we've actually hired some folks that you can call whenever you need who can help walk you through what's going on. So think of newborn screening as sort of a different paradigm. The classic medical paradigm is you get sick, we figure out what's going on, we look at your symptoms, we make a diagnosis, we prescribe a treatment, and then we try to get you back to a state of health. Newborn screening, the basic idea there is we're trying to get to you before you ever get sick. The idea is that we pick up an abnormal metabolite, an abnormal screen, and then we approach the patient and the family and we institute treatment before the patient ever becomes ill, with the idea of preventing damage, long-term consequences from the disease. And by and large, it actually works out that way. It is a public health program. All 50 states have newborn screening programs now. Washington, D.C., Maryland, and Virginia have fairly advanced systems, so they tend to use the more expanded panels. Actually, when I was back in Tennessee, we did the same thing there. Like I said, the things you're trying to prevent and sort of the classic things we look for, things where we could stop or drop mortality, but we could also decrease morbidity. With PKU, the untreated patients don't die, but they are severely mentally retarded and require institutionalization. Up until about 10 years ago, China did not actually do newborn screening for PKU because they felt the formula costs were outweighed by what the treatment was. What they found, though, is so many of these patients had very, very high long-term lifetime health care costs that actually the risk-benefit ratio, or the benefit to society and economics, was to treat these patients. So they've actually started a very aggressive newborn screening program and are treating these patients now. But the rule of thumb in newborn screening has been about every dollar you spend in newborn screening saves about $7 in long-term health care. That's some data out of Australia and also some data out of the United States over the long haul on how these patients do. What we look for are markers that are easy to detect and fairly reliable in blood spots. That's sort of your classic newborn screen. In the future, we may start doing cheek scrapings for DNA, things like that, but for right now, we're still doing the good old blood spots. I don't know if any of you, I've had the pleasure of meeting Dr. Guthrie very, very early in my training. He's the father of newborn screening, developed the Guthrie test with the Guthrie cards. How many people remember Guthrie cards? I was going to say any of us who don't have gray hair on that one. But basically it was a bacterial inhibition assay where the bacteria needed phenylalanine to grow and then would grow and expand. It was really revolutionary as far as being able to do mass screening for a biochemical disorder. Many of you still refer to newborn screening as the PKU test. Hang on. So that's kind of the classic. It was one test, one disease, that one card went for that one thing. But now we do it a little differently. Now we do it by tandem mass spectroscopy. So we take those little blood spots. They use a fast atom bombardment system. It actually vaporizes the blood spot, and then the different atoms in there are detected and quantitated. So not only do we look at the amino acids such as phenylalanine, tyrosine, and things, we look at fatty acid compounds, we look at organic acids, and we can actually measure a tremendous number of compounds off of this. In fact, so much so that we have to limit the peaks we look at. So one of the things you should be aware of when you look at the newborn screening panels that you're running, they are not actually reporting out everything that you could possibly read off of that panel. A couple of reasons. For one, for some of those peaks, there aren't good standards for what's disease and what isn't. For some of them, there is no disease associated with them. And for some, the false positive rate is so high for that peak that it would overwhelm the ability to detect a patient with the actual disease. So for instance, if you had a false positive rate on newborn screening of 5% for a particular test, it doesn't sound too bad, but let's say Maryland has about 80,000 new births a year. If you have a 5% false positive for that, suddenly you have a tremendous flood of patients coming in there. And if that's for one test, if you have multiple tests that have that high of a false positive rate, you have to be very careful. So when we first started doing tandem mass newborn screening, one of the first things we had to do is start dialing down the levels at which we were calling patients with disease. So we knew we were having to trade off. So in newborn screening, there's a trade-off. We trade off missing a few positives versus having to bring in almost every patient for retesting. So do keep that in mind. So a normal newborn screening is going to catch almost everything, but there is a small chance it could still slip through on that for the diseases we're detecting. And we'll just skip through that because y'all don't need to see it. Here's what they look like. I don't make a pretension of being a analytical type with a tandem mass spectroscopy. Fortunately, we just hired a new gal from Stanford who loves looking at these peaks all day long and the different carbon lengths on those. And I can read them, but you don't want me doing that. You want her doing it. But these are fairly well standardized, and it's actually a very sensitive technology. Now, newborn screening can lead to improved health outcomes, but there's a downside to it. And I've been doing this long enough to really know what this is. So imagine you're a family, just took home your newborn child, everybody's relaxed, baby looks fabulous. They've got a little Band-Aid on your heel, but you don't really pay much attention to that. You figure they checked the hematocrit or something like that. And suddenly you get this call from these people you've never met from a state agency saying, by the way, we just got your baby's lab results back, and they may have a deadly disease involving an organic acidemia that has a very high likelihood of killing them, and we need you to call your pediatrician and go see them very quickly. Or you, the pediatrician, get that call to do that. And if you don't think that generates some family stress, you haven't been doing this very long. There's actually some rather interesting studies showing that the patients who are false positives for newborn screening, the parents tend to be more hypervigilant. It's not quite as bad as your classic vulnerable child syndrome, but it's not too far off of it. So you've introduced a pathology into that simply by making the phone call to try to follow them up. Because they never, you may say, well, the second test was fine. Well, they're still like, well, why was the first test abnormal? And we're going to wake up, one morning and our child's going to be missing or whatever. So we do induce a lot of stress through these programs, and unfortunately that's just kind of part and parcel of what we get. Currently what we do, it's a blood spot type methodology, but we've actually tried to cycle it through before we call you. First, about 10, 15 years ago with tandem mass newborn screening, when we got that abnormal screen, we immediately called. What we do now, unless it's just an absolutely sky-high level, we do is we go back through a secondary testing, we'll punch a second spot on that. Tandem mass does not take long to run. You can do those in an hour or so. We'll rerun the sample back through to make sure that analyte is indeed true and there wasn't like a piece of lint on the lens on the detector or something like that. So there's a little bit of quality control in that before you get that first phone call. All right. So the uniform panel. So 1968 here's how we made decisions. And I used to sit on the Tennessee newborn screening panel, and this is actually how we did these. We would sit down with someone from the state legislature office, calculate the cost of untreatment or non-treatment for a particular disease. We couldn't really factor in sometimes the ones that would kill children because that's a little hard to put a price tag on. But for the ones that resulted in permanent disability, we would actually factor that in. So we wanted to identify treatable illnesses detectable in the newborn period where pre-symptomatic initiation of treatment was beneficial. Those were kind of the keys to the whole thing. Now, the flip side that most people would forget, and with the new introduction of some of the tests I think people still get, you've got to have the resources to follow up. So, remember how I told you about China a second ago? We just got back from visiting over there, and they'll be screening 12 million newborns a year in China. That will result in a minimum of 1,000 new PKU patients per year. I have more biochemical geneticists at Children's National than currently are practicing in mainland China. So one of the things they're actually suddenly kind of going, oh, we have built it, they are coming, how are we going to feed them? Fortunately in the U.S. we've got a much more mature system. PKU is not new to us, the other diseases are not new to us, so we actually have the infrastructure to treat these things. But that's one of the things you have to consider when you introduce a new test. And some of the newer tests that are being introduced right now, that actually is going to be a bit of a problem. There has to be evidence for substantial public benefit and acceptance. That's where some of what I would call the political tests have made it through, where celebrity-type government individuals had a family member with the disease, and then subsequently newborn screening has been introduced for that disease in a couple of states. So we kind of get that every so often. An acceptable cost. The cost has actually come down for newborn screening rather than going up. It's actually simpler to do the tandem mass spectroscopy test and cheaper than it was to do the old Guthrie test because of the manual labor involved with that, as well as the old galactosemia testing. So actually, that's one where it's dropped. I doubt y'all see any reflection on those savings. 2006 criteria from the American College of Medical Genetics, which is pretty much what drives policy in most states on newborn screening. Clinical characteristics has to have a burden of disease if untreated in the newborn period. It's kind of just a restatement. I don't know why we felt the need to come back and say that again, but we did. Analytical characteristics of the screening test. It has to be easy to do. It has to be something you can turn around rapidly. It does you no good to do a test that takes 6 months to get a result back on if the symptoms are going to hit the child within a week. And we've actually turned down some very promising newborn testing based strictly on the fact that you couldn't get the answer back in time to do anything. This is going to get to be a bigger issue as we start using DNA for newborn screening. Because currently, given our current technology, the turnaround times on these are not fast, and we may actually miss our windows for intervention. And then finally, diagnosis, treatment, and management of the conditions in both acute and chronic forms are available. Same thing we kind of talked about before. We have to be able to do confirmatory testing. We have to be able to actually turn it around. All right. So this is kind of where we are right now. So we actually worked out a scoring system for what tests we newborn screen for. We kind of used PKU and MCAD as the gold standards for those and kind of looked at assigned point values for all of these criteria I told you about a second ago, and then went through our list of biochemical diseases and screened them. And here's kind of where the cutoff falls. At a score of around 1,200, we try to screen for the diseases before that. The ones below that are kind of arbitrarily not recommended for screening right now. And we keep dropping that down as time goes forward. So we had 29 primary targets, 25 secondary targets, and not yet ready for prime time targets yet, like Krabbe's disease, which they're now doing in New York State, as well as some of the lysosomal storage diseases, as well as Fabry's, things like that. So, this I will not bore you with, but basically it just tells you, and since you'll have this in your handout, there is actually a continual reevaluation process of diseases and technology availability for evaluating newborn screening. HRSA has a recommendation set for it too that we work with from the American College. So I should tell you, I sit on the standing committee for newborn screening for the American College of Medical Genetics, and we just met last week, so this is all pretty much up to date. So 31 core conditions we're screening for. 20 are detected by tandem mass spectroscopy. 3 are hemoglobinopathies. 8 others we do by a variety of tests. 2 new ones on there. One is SCID, which they're having to work out. That's combined immunodeficiency. They were working that one out by a DNA methodology, which has proved very difficult to do, so many states are trying to roll it out, but they're having a lot of trouble doing it. I suspect there will be a fair number of false positives with that. Don't be surprised if you get calls about SCID over the next year, year and a half. 25 secondary targets also detected by tandem mass spectroscopy for different metabolic diseases. And this is also for your handout, and you can get a copy of this. I'll be happy to provide it. But these are the current HRSA panels, which we are doing in all 3 regions that we cover here, and the diseases you'll find. Some of them you're very familiar with. PKU, MCAD, maple syrup urine disease are okay. Then you get ones like 3-methylcrotonil-CoA carboxylase deficiency, which I just needed an excuse to say. But we're not even sure it's a disease yet. We see patients with this. We detect the metabolite. It's not normal. We think it may cause some pathology in some patients, but we're not entirely sure yet. So with some of these, we're still kind of scratching our head a little bit. It ain't right, but we don't know if it's broke or not. So sorry for the Tennessee accent on that one. But there's a lot of these on here, and some of them which we can't do quite as much about. Some of the CPTs, carnitine palmitoyl transferases and stuff. So we'll just go through there. So anyway, so that's kind of a summary of where we are with newborn screening. Here's what we're doing in different states. Like I said, D.C., Maryland, and Virginia are all high-end screeners. So you can consider yourselves right up there with the best of the best as far as what's being screened. Performance, this is some data out of the Mayo Clinic and some of the Region 4 stuff. They screened 517,000 infants. That's about 1 year for the state of New York, 1 year for the state of California. Texas does about 400,000 patients a year, but they do 2 screenings, so they're actually screening 800,000. But out of that, about 329 positives out of 517. About 384 false positives. Those are ones where they were pretty sure something was going on, even with a second screen on that patient, and called them in for a terminal workup. That's actually an improvement over our historical numbers. It used to be it would be about a 5-to-1 ratio of false positives to true positives. So actually, that's gotten a little better as far as that goes. We used to have to run special clinics in a good genetics practice for just following up the newborn screening patients and seeing what was going on. So sensitivity is pretty good. Specificity is about 99.93%, which if you know about sensitivity and specificity, those are actually pretty good for the test. That 100% is a roundup. There's no such thing as 100% anything. Positive predictive value is about 46%. So if you've got a strong abnormal newborn screen, the odds that something may be wrong there on your follow-up screen, not your initial screen, on your follow-up screen are actually quite high. So it's almost 50% of those patients are going to have something. It may be very mild, but they're probably going to have something. False positive rate tends to be quite low. When you're looking at 517,000 patients, only have 384 who have false positives. So as a test quality right now, this is pretty good stuff. You're not likely to have a lot of blind alleys to chase down or a lot of patients that you are going to scare unnecessarily. We're still going to miss a few. We do. Kids that get transfused, folks that are born prematurely that don't necessarily get tested properly in the nursery and don't have well-arranged follow-up. Kids that are in and out of the hospital a lot and that test never quite gets done or the follow-up never quite gets done. One of the things we've been working on is making sure we have tight coordination with the state newborn screening programs so we can help you guys out with follow-up. This just kind of runs over what you'll see as far as the positive predictive values. The amino acidopathies and fatty acid oxidation disorders are the best. Remember, fatty acid oxidation disorders, the primary one we detect is MCAD, medium chain acyl-CoA dehydrogenase. That's the one where when you run out of gas around 6 months, your blood sugar falls, and in some SID studies, it's about 5 to 6% of kids with SIDS. I haven't seen a kid die from this in probably the last 15 years. First 10 or so years of my career, we saw quite a few die from this. Organic acidemias have a good positive predictive value. Then it tends to kind of fall off from there. Congenital hypothyroidism, interestingly enough, even though we've been doing that a long time, still the odds are that if you get a positive, that it's a true positive, are still only about 1 in 4. Cystic fibrosis has a very high false positive rate. Always has. It depends a little bit on the methodology. you're using, but has a fairly high false positive rate. Galactosemia, the same thing. Do y'all know why galactosemia has such a high false positive rate? Summertime. How many of y'all have seen that you have lots of galactosemia positives in the summer? Yes. Mainly it's because the enzyme is heat inactivated. And so when you take the newborn screening card, you get the dot on it, and you stick it in the mailbox, and it's outside in the heat, that inactivates the enzyme, and you'll get a false positive off the card reader. We actually had a hospital in Tennessee where about 1 in 4 patients had galactosemia. Now, this is Tennessee, the home of the circular genome. Now, there's a lot of consanguinity going on down here, but not quite that much. It's a Tennessee joke. So we actually went out to the hospital to see what was going on. And what was happening is they were bundling up their newborn screening cards every day, putting them outside in the mailbox. The mailbox was sitting on a hot pavement in the parking lot. The inside of it was about 120 degrees. And they were basically autoclaving all of their newborn screening cards. There was no bacteria growing on them, but also their galactosemias were almost all abnormal. So you will notice a spike in this during the summer. It's still got a pretty good positive predictive value, but also, like I said, if it's August and you got a positive and the child looks fabulous, you can tell the family maybe not to panic quite as much, although I'm not sure how you tell them exactly to do that. Hemoglobinopathies are pretty good as far as their positive predictive value goes as well. Minnesota data, the reason I show you that, that's actually the group that has done the most work on collecting this. This is work done by Piero Rinaldo and Dieter Mattern up there, who are on the committee that I work with. So, what does that mean to you? We talked about a positive value on the initial screen. It means that if you've got, where we've done that 2 loops and we call it a positive to you, there's a pretty good chance that child's got something. Enough so that you probably don't want to sit on it. So one of the things I've seen that a lot of us were taught early in our careers was that the newborn screen was more likely to be normal than abnormal, even when we got an elevated value on it. And then, if the baby sounds okay, we probably don't need to worry about it that much. You probably need to treat them a little more seriously than that. One of the things we learned the hard way with the patients I've taken care of is that these kids will look great, and then they will turn bad very quickly. Recently had a galactosemia case that had had a frankly positive galactosemia, no enzyme activity at all, and hadn't really gotten chased down. This didn't happen in Maryland. This happened in another state nearby. I will not name it. But this patient had already been hospitalized once for an infection. Still, nobody had followed up on that newborn screening. They thought, it's a galactosemia test. It's not that big a deal. Child came into our intensive care unit on a ventilator in liver failure, and fortunately did not die. And the brain fortunately did not herniate from the high ammonia levels from the liver failure, but that child got about as close as you can and scraped out of it, and yet this was a completely treatable condition for this patient. So you really do want to take these seriously. I know it's a pain, and it really can be a pain in this, taking care of these. So, there we go. So what do you do when the lab calls with an abnormal result for newborn screen? How many of y'all are in Virginia, first off? Okay, how many of y'all are Maryland? How many are district? So you have 3 different systems. So we've had to learn to adapt. I just had one system in my previous job, so we've adapted to 3 different systems. So the first thing you should always do, and this is true for all of you, this is a multiple choice question, is tell yourself not to panic. There are systems to do this, and usually you've got some time to at least take your pulse and think about what's going on. It's not like they call with a seizure. Make sure you get the necessary information. Now, in Virginia, what they typically do is call the pediatrician's office, but they don't notify the potential treating metabolic center about these cases. We're working very hard to get them to do that so that we can work with you on this. Maryland already does that. If Maryland gets an abnormal, they call the pediatrician's office, but they also notify us so that we can work with you on that. And the reason that's important is for some of the large birthing hospitals in the region, the listed pediatrician on the newborn screening card may have absolutely nothing to do with that child's care and not even know where they've gone, or be almost kind of a Dr. Smith kind of thing on some of the cards. So we want to make sure that we find the actual pediatrician or pediatric practice that is going to be working with that patient. You can ask around your colleagues and see what they do. You can ask them what a C5 hydroxy elevation of 12 means. I hope if y'all know that, I've got some job openings, and we would love to bring you on board. Or you can call us. And when I got here, we weren't probably the best organized around that. People were working pretty hard to do it, but they were understaffed. Children's has been kind enough to allow me to staff up on this. I think they are losing money hand over... There's no senior people. Good, yeah. They're losing money on this. But what I did is I brought in a newborn screening nurse practitioner, and her specialty is only newborn screening. So we've got a single number you can call any day of the week, and our on-call physicians any time of night or any time of weekend. I don't know if anyone's had a chance to use it yet or not. She knows what the levels mean. She knows what the follow-up is. She knows what the next steps are. She can work with your staff or with yourself to make sure that things get done right, even if it's all in your office, and help you out with that. Or if they need to get confirmatory testing or secondary testing, we can help set that up too. So yes, that is a shameless plug, but considering that plug's actually costing me about $100,000 a year, and we don't really make that much off of it, it's one that's more something I think we need to do. I do not want to see a child die in this region from a missed newborn screen. That just simply is not acceptable. So if you get one and you don't know what to do with it, or even if you're not even a little bit unsure, give us a call. If you cannot get hold of them, you can get hold of me, and I will make sure they get hold of you too, because I have to sign their paychecks. Now, the final thing we've had is, the answer I've gotten from some physicians is, I'm self-sufficient and I Googled an answer. Google does not currently keep up with all of the newborn screening, but you can eventually end up at the American College of Medical Genetics site, where they have these wonderful fact sheets about what to do with different abnormal newborn screenings. And it links back and forth to the American Academy of Pediatrics webpage. And those are pretty good, actually. It will explain what's going on, what some of the next steps are. But as far as the mechanics of this, let us give you a hand whenever we can. And like I said, it's not really rocket science. We're geneticists. We're not rocket scientists. So what else to tell you about this stuff? The act sheets are useful. They'll have some of the algorithms in hand. There are programs to help you guys out with this. This is important. I mean, if you think about all of the tests we're doing right now, the percentages are getting high enough where it's, you're going to start picking up a few patients. How many people follow a PKU patient in here? 1, 2, 3. They're probably, for every 10 to 12,000 patients, there ought to be one PKU patient. That's about the incidence in this region. It varies a little bit from region to region. It's about 1 in 15,000 where I came from. It's about 1 in 10 to 12,000 here. Mainland China is about 1 in 8,000. Don't really understand why that is the case. But there are things you can do with these. So we're not going to even talk about galactosemia in this case, other than the fact that galactosemia has a couple of variants, and that's the other point I want to make to you guys. Some of these have either ethnic-specific variants or enzyme variants that may have different implications for diseases. For instance, positive galactosemia, there is a variation that affects red blood cells' ability to clear galactose from the bloodstream that will give you a false positive. It's primarily only in African Americans and folks from Western Africa. There's also a Duarte variant on that will give you a positive that will not give you a clinically significant disease. So galactosemia all by itself is actually about 4 or 5 different diseases rolled under one roof. Now, they're pretty easy to sort out if you know what you're doing, but the nice thing is there's only 1 or 2 of them that you actually have to treat. The others you just monitor. So what's next? Okay. There's some new candidates coming out that really start to raise the bioethical issues that surround newborn screening. So currently, newborn screening is not really, it's not really optional. It's pretty much everybody gets it. There are some ways you can get around it. You can get out of it for religious reasons, which I have seen very, very rarely done. But by and large, it's considered health policy, and pretty much every kid gets it. Capture rates tend to run about 98, 99% of newborns, depending on whether you're in a rural or an urban area. And they've expanded into a couple of new things. Lysosomal storage is the one that's probably the most controversial in my field. Take Pompei's disease, for instance. Newborn Pompei's disease has almost always been universally lethal. There is enzyme replacement therapy for Pompei's. The measure of efficacy for that is that after a couple of years, the patients have about a 10-yard improvement on a 5-minute walk test. It doesn't necessarily extend life. It actually tends to prolong the condition some. And so there's even a lot of controversy in my field if we should be treating the newborn patients with this in the first place. But yet this is something that is becoming included in some newborn screening panels to look for and potentially treat. There are some patients that actually do fairly well, but a lot of them don't. Fabry's disease is another one. As pediatricians, Fabry's is not on your radar. Fabry's disease typically attacks folks in their 40s to 50s with progressive chronic renal disease. So what are the odds that newborn screening for that is going to be that tremendously useful? Are the parents going to remember to tell them on their 18th birthday, oh, by the way, 20 years from now, you may get some renal disease because of your abnormal newborn screen that you had way back when. Here's this faded card for you to call these people and ask them about it. But those are the sorts of things you get. Severe combined immunodeficiency, the treatment for that, of course, is bone marrow transplant, which has its own issues. It's reasonably, it's a lot better than it used to be, but still is one of the things that we've got coming up. So there's a lot of new things on the listing now. We'll see how they go for those things. A lot of these are being done in different places. For instance, Krabbe's disease, which is treated by bone marrow, which has not necessarily good outcome, is done in New York because of a celebrity case. A prominent person in the state had a child with Krabbe's, and they said, why aren't we screening for this? And this person was prominent enough where they said, oh, we don't know. So they put that in the thing, and they don't know what to do with it. They're getting these patients, and they really don't know what to do with them. So it's kind of getting where our technology may exceed a little bit what we can do. All right, so we're going to call it quits there. But the main points to make out of this talk are newborn screening is pretty reliable. False positives are at a low level at this point in time. So if you get a positive, pay attention to it. We'll help if you want us to. If you feel comfortable with it, that's great. But if you ever want any advice, the phone lines are open. And it's one of those things that's had a very positive impact. Not quite as much as vaccinations by any stretch of the imagination, but a pretty positive impact on outcomes in patients. Given that, I thank you for your time and attention, and I'll see you in a few minutes.